room don't know about?
What they don't know about? Well, I would say that the most exciting effort now is our ability to understand what is effective. One of the biggest challenges I think as corporations we have is there are a lot of ideas out there, but how do we know what's effective and how quickly can we be agile enough, and how agile are we in order to essentially double down on innovative solutions? And so I think corporations are more and more wanting to get the data, and with that data be able to make decisions on that data on interventions that they're doing. So as we increasingly release, the issue of data, releasing the data, whether it's an individual wanting their own health data or corporations having a better understanding of the dynamics of what's going on, I think that's a big push right now that I see.
Lynn?
Well, I don't know if exciting is the right word for it, but I think the nature of the challenges that are facing employers in terms of what's happening with health in the workforce. I've got a couple of slides. Sorry, first slide. We have, we're in a time now where we basically have epidemics of chronic disease, which some of us are calling a syndemic, where at the same time we have dramatic changes in lifestyle, dramatic changes in diet. Physical activity is down, caloric consumption is up. And so we're seeing in the workforce more and more diabetes, cancer, cardiovascular diseases, some of the other health problems that are related to this, which is obviously a major driver of many problems, not just health insurance costs, but also absenteeism and other problems. And the next slide. And the thing that I find really astounding, and these are data from the CDC, but people who were born in the 1940s, that purple curve on the right, I mean, the bad news is that it is normal for people to gain a little bit of weight every year as they get older. But the really bad news is that with successive generations, each decade of birth, that weight gain, that rate of rise of weight, it's become steeper and steeper and steeper, and that even worse, that we've begun to see obesity in children. And even though we're learning how to go after that, we're at a point that is unprecedented in terms of the body mass index that people have when they enter the workforce, and then the rate of rise of weight gain over time, where they're supposed to be a little bit naturally, but it's way more than it should be. And so I think that employers are challenged in terms of the level of physical activity of people in the workforce, as well as choices for food and how to better take care of their families in this kind of a setting.
And this is an interesting perspective for you, because you not only have employees, but your primary challenge as a company is to address these types of issues.
It is, and we work a lot now with large corporations. And what's interesting, if you look at everybody who's being more proactive in addressing the lifestyle part of the healthcare cost equation, what we generally find is far and above, you have some pretty sophisticated corporations, self-insured companies that are taking a very proactive stance. If you ask me kind of what I think is the sort of the biggest misperception, is that I think there's a tendency for people to think that there's one thing that companies are doing to address, for example, obesity. That one thing might be, attaching healthcare premium adjustments based on, your current weight and, trying to take advantage of this new clause in the Affordable Care Act. What I would tell you is that from our observation, the companies that are having the best progress in terms of addressing conditions like obesity in their population are doing a lot of different things. So if you look at the Safeways and the Cleveland Clinics and the GEs and the folks like that, you're not going to find them with just sort of one big idea, and that's sort of the silver bullet that's kind of solving all this. What you're going to find is that they're taking a pretty comprehensive approach from things as prosaic as what's in the vending machine, what's allowed in terms of catering and at meetings, getting into health plan design, getting into partnering with people in terms of treatment. They tend to take a full approach all the way around it, and they're doing it with a surprisingly long time horizon, with a recognition that if they don't, because I think if there's one statistic that should be sitting with all of us, is that bad enough in this country that there's 26 million Americans who are diabetic, a doubling of the percentage of population since 1970, but there's another close to 80 million who are pre-diabetic. So that's where the CDC has its forecast that by the year 2050, 1 out of every 3 walking Americans will be diabetic. If you're a large employer and you've got a population that you think is going to be with you for a while, that's a cause for quite a bit of concern, and that's just one condition.
And Sue, what are your thoughts?
So David said a lot of what companies are doing, and GE is certainly doing a lot of those. And I have to say, probably one of the more exciting elements of what's been happening is, in fact, that employees are taking responsibility. It's shared leadership, and certainly we're seeing that within GE. It used to be before, and I think you all know this, particularly here in the US, that employees did not know what the cost of care actually meant. And it's not just about the high deductible plans. It's because they have to understand all the other elements of things, and they start to realize this is shared leadership, shared risk. And the fact that they're actually engaging is not just because it costs them more money. Now, mind you, I think they understand, and we understand, that yes, it will cost us all money, but there's a notion of corporate competitiveness, there's a notion of national competitiveness, there is this notion of, in fact, having to take responsibility, because if you don't, who does for your family? When does your family get really aware? So for us, the exciting part of this is, in fact, people are recognizing how important it is for them not to be just in the passive passenger seat, but actually in the driver's seat as it relates to health.
That's interesting. And Richard, you've been in this industry obviously for such a long time, focusing on this exact issue. Tell the audience something that will surprise them as far as the research and what you've come across.
Well, I see Frida from Pfizer, and she told me to be profound. And if I could not be profound, to make sure that I was provocative, and if I wasn't provocative, to be brief. And I don't think I'll be profound, and the time constraints will make sure that I am brief, but I might be provocative.
You like that?
I might be provocative by saying that the healthcare system is not broken. It's not broken, it's obsolete. We, in the second decade of the 21st century, we're practicing 20th century medicine. We're practicing fee-for-service. The more you do, the more you get paid. Non-collaborative medicine. Medicine in the 21st century will be collaborative. There'll be team approach. There'll be physicians. There'll be nurse practitioners. There'll be physical therapists, all working as a team with the patient at the center. We no longer can do this without innovation. We need technology, and we need no longer to be trapped by intellectual and emotional inertia, which keeps us thinking about the way things were and not the way things are today. The strategy is collaboration. The strategy is collaborative care. So you're not duplicating services. You're not putting people in the hospital who could avoid hospitalization. We have a $3 trillion industry, $3 trillion. The budget for NIH is only $30 billion. That's what, 1%? If we saved 1%, 2%, we've been doing this for what now, 34 years, for the health plans. What we do for the health plans for the last 3 decades, we certainly could do for corporations. The way I sort of look at this is the strategy may be collaborative care, but the tactics are different ways to innovate. One of the things that we've done is incentivize prizes. We try to think of fixed cost science or fixed cost engineering. We have a $3 million Heritage Prize, which we put out to mathematicians, not healthcare people, but so today we have 39,000 entrants in 41 countries working to try to develop a predictive modeling algorithm to see who will be hospitalized in the next year. And if you can predict who will be hospitalized, you can prevent some of those unnecessary unnecessary admits. We also have we teamed up with the National Cancer Institute it's called an Inference Prize, and it uses big data to develop more effective treatments for breast cancer. By doing this, we developed a community of data scientists. And this community of data scientists who in the past had worked on cosmology, particle physics, are now realizing that healthcare is something that they can participate in and help mankind. So we developed a series of challenges, smaller challenges, and we've asked the public to select what America wants. What are the questions that America wants, vetted by a panel of judges, and then the judges, including, well, we're doing this with a bipartisan committee in Washington, so it'll be Bill Frist, Tom Daschle, Mike Levitt.
And from a corporate perspective, I'm curious to know if this is the type of research that you as executives will be turning towards going forward in the future.
You know, where I started with data, I think the research it takes so long. We have to be able to look at things ourselves. But I would suggest that what Dick is talking about is this notion of team-based care, and I think it's absolutely critical that that's how healthcare is moving slowly, but it's moving. What an innovation that's happening, though, is workforces are standing up their own patient-centered medical homes. They're beginning to say we are going to get into healthcare more directly because you can put a shingle on your outside of your office and say you're now collaborative, but are you really? And so can we in fact get more involved? And is it more than just the place of care, but is it not just a home but a neighborhood? What does that health neighborhood look like, and how do you extend that through technology, whether it's through telehealth or other technology enablers to extend the scope of care that can be rendered in a much more scalable manner? I think that's something that I see as happening out into in corporate America. The other aspect, I think, is you can have this great strategy and you can have this aspect of team-based care, but at the end of the day, the most important thing is maybe not technology, but it's the culture and the engagement piece. And that's what Sue is alluding to, and I think that's why Health Affairs recently, and I think 2 months ago, they coined the phrase, engagement is the next blockbuster drug. And I think really companies who understand how to engage the workforce, whether it's a health plan or it's a provider trying to engage their patient, whether it's an employer trying to engage their employee workforce, I think understanding how to do that with enabling technology, policies, thoughtful designs is going to be really important as we move forward in order to operationalize some of the things we'd like to do.
And how do you go about tackling that? And specifically, I'm talking about companies of your size. You have nearly 200,000 employees, GE as well, a huge company. You're dealing with unions as well. Where do you begin to chip away into healthcare costs?
Well, I think it's when you really don't have a good solution, what you do is you try, and like we were talking earlier, you take some small bets, you learn, you immediately you change, and then you go again. I just got a text on our latest competition on health. We have a health information portal, and we were kind of hit this level of 20,000 enrollees, and we wanted to get more than that. And so we just launched an internal competition where the store managers were to enroll members, and they got prizes for enrollment. And that's now we've almost 30% increase in a matter of a week of enrollment. So thinking through ways to get, whether it's gamification, competition, the aspect of social proofing, leveraging social media, there are a lot of different tools, and I think we have to be willing to try and then learn and then move forward.
What's interesting when I think about healthcare and kind of the challenge of it is you asked rightly, I think, the question of how do you get a large group of people to start doing things differently, and I think what you've heard is, I mean, it's there's a little bit of a tendency, for example, for people to look for the bright, shiny object, and the bright, shiny object might be high deductible plans. Okay, so everybody's talking about high deductible plans.
Right? The
It's,
first step, right?
unfortunately, for what worries me is I hear a lot of folks saying that's the answer. And I think as you heard Sue talk about, the problem is that you would be hard pressed to find a sector of the economy that is less consumer friendly than the healthcare sector. I mean, you can price check airline tickets, hotels, food, TVs, like Lord knows everybody in this room could just rock a serious comparison of a plasma TV set. I challenge you to actually try to, sort of like disentangle your last healthcare bill and figure out like what that meant. And so I think part of the problem that I see with healthcare is that it really needs to, if it's going to get to that point of engagement, it has to do a much better job making it consumer friendly for people to actually make different choices, which is a complete change from an industry that has historically been notoriously just cryptic, consumer unfriendly, probably the least user-friendly consumer-facing portion of the economy.
And let me just comment a little bit on your question, Bianna, because I loved what David said at the beginning as it related to long-term, because this is long-term. Behavior change is long-term. So how did GE go about doing it? Now, mind you, I've only been at GE 10 months, so I have been peeling this onion very, very slowly to try to really figure out how have they made this work, because it's been quite remarkable. But just like any other business process, so supply chain management, putting performance appraisals into place and making them go throughout the organization, any business process that had been put into place before, they said, we have to create a culture of health, and we have to do it through applying the rigor that we apply anything else and look at it across years versus just trying to do one thing. And it went from health plan design, redesign, to doing things such as you mentioned with regards to food and changing the vendors and the vending machines as to what you could actually have with regards to food, making elevators go slower so you force them to walk up the stairs, right? Making sure that in fact the online tools are available so it's not just a temporary fix, it's something that in fact stays available. And then with GE, we've got over 500 sites worldwide. And so how do you make healthcare not just something that gets adopted in the US because all the issues that we have that are so magnified in the US, it's got to be local. So the notion of being able to engage became something that you start from the very top, and so you've got leadership, but you put volunteer committees, if you'd like, knowing that you're going to get measured on this, and it all goes back to data and measurement, and you really systematically, quarterly, make sure everyone in fact is on board with this. And it becomes a real sense of pride when in fact recognition systems then go into place because your site has met all these various metrics, and in fact people are losing this cumulative amount of weight, smoking cessation has occurred, families start to have testimonials as it relates to on the web how much they in fact have gotten healthier. I think it's a very, very, if you'd like, holistic approach that has to go from business process design and optimization to actual consumer engagement, so it's no longer the patient, if you'd like, and a lot of the data and the metrics and the engagement tools to actually make things happen.
And so if I may, we're actually taking a similar approach within our university. And there's a task force that includes employees from across staff as well as faculty. Some of the faculty actually bring studies, data to the table. And what we've found is that small things can make a big difference. We're experimenting with things like standing desks, which actually cause people to burn more calories all day.
My co-anchor just bought one, actually.
Yeah,
He says he's more productive.
And a little bit of exercise, actually, evidence does show increases productivity. That people who get a little bit of exercise every day are more productive than people who don't. It's kind of counterintuitive. You think if you stick there at your computer, you're going to get more done, but it turns out to be untrue.
Right.
And things like electronic supports to get up and stretch, to move around, to help with smoking cessation, to help with diet and weight control. Those things are things that some of our faculty are developing, but we're starting to deploy with the workforce. Stairs, walking, all of that. I think it's very important. The other thing that the employees bring is the concerns about their family, and that they want to have places where they can breastfeed, where they can, take care of their infants. They want childcare nearby. They want to be able to have areas where they can safely walk, which we fortunately have around our campus. And more of the employers that I'm talking about are also doing very innovative things there with trying to make attractive areas for people to actually go outside and walk and even do walking meetings, so that, to just encourage that activity.
Well, we know the cause of the problem, right? Unhealthy behavior attributes to 70% of healthcare costs and rising costs. But how do you tackle it in the way that, we've seen some companies now, ban people from smoking?
Well, in fact, we're going smoke-free on our campus as of the beginning of September, which is not easy in an urban environment, but it's,
But where do you draw the line? I mean, is it a carrot-stick approach that works best? Do you force your employees to join a gym? Do you monitor how much weight they gain? I mean, what are the parameters here?
I mean, this is, it's interesting. If you start with smoking, in the NEJM very recently, they had opposing op-eds, both coming out of the University of Pennsylvania. Zeke Emanuel wrote one with a couple of colleagues, and Kevin Volp and Dave Ash wrote the other, asking the question, is it okay for a large employer to refuse to hire smokers? Is it ethically correct? And the Cleveland Clinic, for example, will not hire a smoker. And there's actually Penn Health was getting ready to move to a policy of not hiring smokers. And what was interesting is that even in the discussion we were having with them, with a number of other folks, is that it wasn't that clear that it actually was ethically correct. Because particularly if you believe smoking is correlated with low income, you get into tricky issues, which is, are you sort of further ghettoizing people who are coming from a low income strata and pushing them so that they're no longer qualified to work for sophisticated blue chip organizations. And so as I'm listening to this whole discussion, my response was, well, if this is hard for smoking, where do you start with obesity?
Yep.
Because honestly, this is effectively been my life's work. The biggest misnomer of obesity is that people who struggle with weight choose to do so. Obesity is mostly an environmental issue, of which people that were wired through systems riddled throughout their body and brain to be perfectly optimized for a world of food scarcity are now in a world of food overabundance. I'm not blaming anybody. But nonetheless, people are merely doing what God intended them to do, which is to respond to their environment need. And so that doesn't mean that there's not a level of personal responsibility. There is. But I think that I hear of a lot of employers that are kind of going down with, the stick in hand, that are going to be hitting pretty hard saying, we're going to have big fat penalties if your BMI is greater than 27. You're going to pay, we may even kick you off into a Medicaid exchange. It's some pretty tough stuff. And I think that my prediction is that people who take an overly stick-based approach are going to find that it doesn't work. And I think the people that are looking at that, when you look at, so for example, Safeway gets a lot of press for doing what I think has been misunderstood as a stick-based approach, when in truth, when you actually look at everything Safeway has done, it is much more supportive in helping, with an intent of helping people than it is with an intent of punishing people. And that's the same thing we see with Cleveland Clinic. And it is a very different mindset, but I really think that right now one of the concerns I have is that I think there's a lack of good information out there that a lot of large employers are using to make decisions on how to try to sort of solve some of these things with a couple of silver bullets so they can get the whole thing taken care of, and not recognizing that if you don't do this the right way, it really can blow up on you.
David, doing it the right way, I think is correct. We have 80% participation voluntary in our program. And so that is critical. I appreciate you saying that. It's how it's perceived. It just dawned on me as you're talking, though, that with your very first question, Bianna, I think to the point of experiences shape our beliefs, our way of thinking, which create certain actions that end up in a result. And you take any behavior, that experience, belief, action, result continuum essentially is in play, right? I mean, that's it. So I think one of the interesting things that I'm seeing happening out there is getting into the mind, into how is it that we think about something? So how do we reshape experiences or begin to help individuals reframe their perspective on certain things. And so there's some interesting technology now that is coming out there as well that helps begin to look at the mind. Some people call it resilience. It's other aspects, but I think that's another interesting area. And we at Safeway are also looking at that. We're very much interested in how we can. And so it's neither a stick nor a carrot. It's a support mechanism on a person's journey.
And so much of it can be personalized now due to technology. So I see a lot of people walking around with the Nike Fuel bands. People have Fitbits.
Right.
There are a lot of apps out there that people can use at home or at work to monitor their caloric intake and how many steps they walk and what have you.
So what are the outcomes in American manufacturing? There's more money spent on healthcare than the steel in an automobile, for example. There are huge variations in costs. There was a great article in Time magazine, if anybody read, about a month ago, talking about the costs in hospitals, that their charges were just opening bids. Our healthcare conundrum is causing us to be less competitive nationally, less competitive globally. Our competitors want to eat us for lunch. We can be at the table or on the table. I don't know about you, but I'd prefer to dine. So I think a lot of what is done is not cost effective. I think there's a lot of waste. I think there's a lot of process. Something you mentioned earlier is being able to do something rapidly. What we do is we have something called a 3-3-3 rule. So anybody in our company can get together with up to 3 people. They have $3,000 to develop a new process. They have 3 days to do it, and they have 3 weeks to implement it. If it works, terrific, we spread it out. 19 out of 20 fail, and we applaud and we have little hurrah, but we encourage people to try rather than having a committee, to form a committee, to form a meeting, to form another committee, to think about a grand prize or a grand process. We try to do rapid deployment, and that has been extremely effective for us.
I want to turn to healthcare legislation coming online next year. Obviously, we know as a nation got a lot of pushback from corporate world and executives, but as far as moving in the right direction, good thing, yes?
Which of the legislations are we talking about?
There's so many things that are happening.
So for example, we spend $280 billion on what is called the dual eligibles, and these are Medicare and Medicaid. And you'll find this interesting in that Medicare pays for hospitals and Medicaid pays for skilled nursing facilities. So the hospitals try to push patients into the skilled nursing facilities because the state pays for it, and the skilled nursing facilities try to push patients back into the acute care hospital because the feds pay for it. So patients get ping-ponged back and forth and back and forth. And it took, at least California, just agreed to combine that to give one individual or one organization responsibility so ping-ponging does not occur, and we expect that to save billions of dollars just in California alone. So in that case, that was tremendous and terrific legislation.
I mean, I think overall, a lot of the changes are going to be positive for consumers. People who are covered by employer health plans are probably not going to notice much of a change at all. In terms on the consumer side, people who are buying into those plans, there may be, over the next year or so, some changes in rates. There's a lot of uncertainty right now about rates until all the exchanges are mounted and that market goes to work. At the beginning, it's where that market is set is not going to be where it's going to be in a few years. But so there is uncertainty about that. most of the states do know how to run markets. So they ran markets for the Medicare drug program, and the ones that are setting them up do know they are capable of doing it, and as does the federal government, know how to do it. However, there's also some problems on the implementation side with things like the budget sequestration. Some of the funds that are needed for these transitions aren't there. And Health and Human Services is scrambling also to get rules in place that because there was so much uncertainty. We think this thing was taken to the Supreme Court, and they didn't even rule until, a couple months before the election.
Right.
And then we had the election, which some people thought would overturn the whole law, and it didn't. And so there was a lot of uncertainty in the states about whether to move things forward. Some states are moving forward, and things are very organized in those states. And other states have been kind of late to it because they thought they wouldn't have to do any of it. So the next couple of years are going to be a little crazy, but I think that overall for consumers, it's going to be better because, not only because the exchanges are going to help them, but obviously people with pre-existing conditions. To have had a situation where if you're born with a birth defect, you can't get health care coverage, it's crazy. Yeah. And so many of those things are going to make a big difference for consumers.
It's going to be an interesting next couple of years for sure. Do you want to?
Yeah, I would definitely say it's a forcing function. It's here. We're having to make changes. I think the devil's in the details on some of the implementing instructions that are going to be released and have been released, and so we're looking at that to see how whether or not there's a perspective that needs to be brought to bear on some of these instructions that come out. But one of the things it's doing, though, within the healthcare system is that health systems, if you think about large hospital systems, have been working in a wholesale environment. They have been selling to resellers, the health plans, the health insurance. And now with the fact that they're going directly to the consumer, they've entered a space of retail, and they're trying to figure out how to become more relevant to a consumer directly. And I think that's going to be an interesting dynamic that begins to play out.
But when they do that, what's the greatest cause of bankruptcies in the United States?
Healthcare.
Okay.
Yeah.
So if you have insurance, your insurance company may pay a fraction of what the hospital charged. But if you don't have insurance, they charge you full charges. And I actually have a slide on 3, if someone could put that up.
His slide. Actually, that's my slide 3.
Oh,
You went his slide 3. You need to actually go to a different.
We'll get there.
Well, the bottom line is, for people in California, Cedars says that they lose $1,200 per day for every day a Medicare patient is in the hospital. And yet UCLA makes money on Medicare. And yet UCLA charges twice as much as a community hospital. So if you have a tertiary, if you need a liver transplant, you don't want to go to a community hospital. If you need a heart transplant, you don't want to go to a community hospital. But UCLA or any of the academic tertiary care centers, they cannot perform a hernia or a gallbladder as effectively, cost effectively as a community hospital because they have such a huge infrastructure. So they charge, Don, what would you say, $15,000 a day? Yeah. So a typical admission for a UCLA would be a 4 or 5 day stay at $15,000 a day. What a community hospital, so that's $60,000, $75,000 for an admission. And a community hospital might be, in today's world, 6, 7, 8,000. Huge difference. And again, there's no transparency. People don't know that.
Still so many inconsistencies.
Can I just comment, like it or not, with regards to the legislation that's being put into place? What it's done is create a national dialogue in a way that we've just never had.
Yes.
And this notion of shared responsibility and shared leadership, now we don't have a choice. And so one of the things, and again, I'll just describe GE, and that is the discipline of health and culture that we're talking about within GE because of this whole notion of the conversation that's occurring outside, our chairman said, okay, if we're going to do this and folks are going to take responsibility, we have to extend this even outside our communities so that communities can be experiencing some of the benefits too. And so we take as an example, we've now gone in, we have something called our Healthy Communities Program with Cincinnati, Erie, Pennsylvania, Louisville, Kentucky, and we've got a couple more that are going to be announced this year. And this is where GE has had a footprint and said, we want to extend a lot of the tools that we've actually put into place within GE, a lot of the processes, the data gathering, the types of things we've learned over the last 3 years as we established these programs, and put them into the community. Now, you might say that rings a little bit like ACOs and having, in fact, shared alignment with respect to the goals that are being achieved. Well, it is. And it
Accountable care organization.
accountable care organization. And people have had a little bit of allergy to that, right? And we didn't say we're going to set up an accountable care organization. We said we're going to figure out what aligned goals are to figure out how to improve quality, access, and affordability as it relates to health care, in Cincinnati as an example. The results that are coming back now, and it's only been 2.5 years, almost 3 years, is that, as an example, self-reported in the Cincinnati community, and these are 19 large self-insured employers, 10 hospitals and provider systems, along with a whole bunch of government agencies, et cetera, are coming back and saying, we've saved ourselves $200 million in just ER admissions. In terms of asthma and diabetes, which were the two places that we said we're going to actually measure, the increase in satisfaction and quality in care, measured by a number of different metrics, increased radically. I mean, 50%, 76%, just as an example. We put into place the physician-centered medical care, if you'd like, patient-centered medical care, the medical home, being NCQA qualified, and all of a sudden, goodness, again, the satisfaction rates, because you had this continuum of care of someone looking after you, became very, very high. It's all of the things that have been sort of fragmented and have been talked about in a very fragmented way, getting them unified. It sounds so easy, and I know it's not, but yet it is.
Right. Well, and becoming more efficient clearly is part of the solution, but isn't the larger solution just to tackle the problem at hand, and that's lifestyle change?
Well,
I mean, I just want to, these statistics are staggering. Obesity, the number 2 cause of preventable death in the United States. In 2013, obesity, number 2. 60 million Americans 20 years and older are obese. 9 million children and teens ages 6 to 19 are overweight. Yet the diet industry is a multi-billion-dollar industry, booming. Where is the disconnect?
well, okay, couple things on that. First off, the diet industry, like 45 billion. Just so you know, that statistic includes diet soda. So, as with all things, be mindful of source data,
Right.
which I'm in the industry, so I have to know these things. Here's maybe my very simplistic way of thinking about kind of what has to happen in healthcare, which I think you raise a really important point. There's two aspects of this and kind of two conversations, and they definitely connect. But one is we have to re-engineer the health system to make it much more efficient, aligned, have responsibilities happening in the right place, have collaboration happening in the right place, all the things that talk about bundle payments, patient-centered medical homes, accountable care organizations, sort of that whole territory. There's another part of the conversation, which is how do you go about the unbelievably difficult business of getting people to make different choices in their daily life? It is absolutely a health issue, but the healthcare system is absolutely not historically aligned around or doesn't even particularly think about how do I get you to do different things over the course of your daily day. They don't frankly even generally see you until you come in when there's something wrong. Now, the whole thing in terms of lifestyle change is that the one thing I will tell you is that behavior modification. I swear I didn't say anything unproductive.
It's your IR group.
Exactly.
It'd be a way to get us to run.
I know. This is not a drill. This is.
They just keep going.
Your attention. May I have your attention, please? Our hotel response team is investigating an alarm that is sounding. Please remain calm. We will notify you with further instructions. Thank you.
You're welcome.
Please remain calm because behavior modification, while being difficult, is possible.
Please remain calm. We will notify you with all further instructions. Thank you.
Okay, So the issue with behavior modification that I see is that it's incredibly difficult to do. It is easy to say, it's hard to do. And I'll share with you one insight that we have in terms of what, in the context of obesity, what works and what doesn't work with behavior change. In a given successful weight loss attempt, by far the thing that we find to be the most predictive of someone being successful going through that process, whether it's with Weight Watchers or any other thing that they're doing, is that people who believe that if I simply stick with this and stick with it long enough, it will work for me, therefore the only thing I have to do is stick with it. People who believe that they will most likely fail will most likely fail. It's called self-efficacy. And it is the thing that I think is least understood about a behavior change process, is that most people don't believe that they're capable of doing it. And so therefore, when I think about behavior change, I think of it in sort of like, there's an old maxim in physics, which is that the force required to get an object in motion is different and generally greater than the force required to keep an object in motion. When I think about behavior change, I think about it in terms of what are the things you need to do to stimulate action, and what are the things you need to do to continue action. And that's really where the hard work has to happen. Again, easy to say, hard to do.
So if I can add to that, I think that it is partly self-efficacy. It's also partly the unrealistic expectations that people have. So, you know, if you saw the graphs I was showing, these weight gains happen over a very long period of time. I mean, a dangerous level of weight gain is something like, I think 1.8 pounds a year. Well, who notices that first 1.8 pounds? Nobody. The second one, the third one. The typical thing is at some point in time people turn around and say, oh, I don't fit into the clothes I wore in college anymore at all. You know, I've really changed. And by that point, it's 10, 15 years down the line, and then they notice. But they expect, you know, from the diet industry, the weight loss industry, that they can do a 6-week program and melt right back down to the way they were in college. Well, if it took you, 20 years to get there, you're not going to correct that in 20 days. It's just not going to happen. And I think people wind up having a sense of failure because their expectations are out of whack in terms of reality. The reality of that if it took you that long to get there, your metabolism's changed. It's going to take a while to dial that back to a different state. And the other thing is that people didn't make conscious changes in their lives to say, I'm going to be less physically active. One of the scientists in my school was telling me in preparing for this that every year all of us are less physically active, but we're not aware of that. We're just gradually spending more time at desks in front of screens, being entertained and, at home in front of screens and so forth, behind the wheels of our cars, commuting. And we're not aware of that as a conscious choice to be less active. And we have to make conscious choice to be more active, perhaps, but also we need to actually pay more attention to things like the built environment around people. And somebody mentioned the stairways and making the elevators slower and making walking areas and
fuel bans.
So there are things that can be done where people may not be thinking they're making a conscious choice to be more active.
Yeah.
But they would be more, if they would be more active, they would feel better. And then, to get back to the healthcare system, what all of the incentives have been around are getting sick, being seen, being admitted, fee-for-service, reimbursement for taking care of you. And if you're readmitted, that is incentivized. I hate to say that. If you get a hospital-acquired infection, that's incentivized. There's a reimbursement for that. And so the changes that are occurring in terms of trying to reduce those readmissions, people get out, that things are done to keep them healthy so they're not right back in. Deal with those hospital-acquired infections. That shouldn't happen to anybody. There's no reason for that to happen.
Are you saying incentivize or disincentivize?
Incentivize the reduction of those through the yes, disincentivize that.
But the hospital is actually incentivized. Right
now they are. And so, some of the things that are happening in terms of making healthcare more accountable are that, if your reimbursement is actually reduced because of having readmissions, and there are indeed, some of the provisions of the Affordable Care Act to do that, that's going to make a difference. But fundamentally, and I think, Richard, you said this, that, a lot of us would really like to see a reversal of the incentives. I mean, why isn't the healthcare system incentivized for keeping us healthy? I mean,
Because we
wouldn't
have a
all,
sick care system, we don't have a health
we
care
don't
system.
have a healthcare system, and we would all like to stay at the peak of our health, and we'd like our employees to be at the peak of their health, frankly, as long as possible. You know, because the less disability and the less illness, then that's less absenteeism and more productivity for all of us. People are happier.
Just share some insights from Safeway. You know, we believe that awareness precedes change, and one of the values of our Healthy Measures program is the fact that you don't have to wake up 10 years from now and realize I've got high blood pressure and my cholesterol is now 400 and I now have gained weight, because we have individuals check their biometrics as part of our health plan, and that's part of the opportunity, and that's how we see it, as an opportunity for you to become aware of these changes before they progress too far along. And so we have seen that our healthcare costs have remained relatively flat, 2% over since 2005 to 2012. Last year was a little less than 1% growth over health plan spend. But we also have noticed that we looked at our biometrics, and individuals are staying they're fighting through a cohort analysis, they're fighting the normal effects of aging.
So you're talking about more of a focus on preventative care.
Right.
Maintaining the day-to-day.
And responsibility and giving lots of different opportunities for individuals to be engaged in their health. And it does work, because we essentially view ourselves, and to Sue's point about these communities that GE is involved in, you know, we are a community in and of ourselves. And so I would be remiss, my CEO's talking right now in a CEO roundtable, and he has been the leader of this, and he's been not only the thought leader but the champion, which it takes that kind of leadership. But I would say that he is looked at from a community perspective on lifestyle, the role that and the culture of looking at alignment, aligning the incentives, understanding the dynamic of alignment, understanding how to engage, and then how to focus on the environment. And those are the levers that a leader has to really focus on. And I think our CEO has done a phenomenal job of doing that. And I believe that those are the kinds of things that a community at a time, we can really begin to change the health of the nation as we embrace this in a much more widespread manner.
You're giving me a great segue, since you just mentioned your boss. I spoke with him last night, and I asked him his thoughts on, Mayor Bloomberg's attempt in New York to ban sodas after a certain size, and the nanny state debate that ensued following that. He did not think that form of legislation was productive. And I just want to ask the panel your thoughts on that.
Well, that goes back to Karen's stick, doesn't it?
Yeah.
I don't want to comment specifically on whether we agree or don't agree with what he did. I can only tell you the approach that we've tried to take on figuring out what to accept and what not to accept, what to incentivize and what not to incentivize within our organizations. And really, it's been quite a balanced approach, to the point that you made earlier with regards to smoking. So we went smoke-free every single campus at GE around the world. This is around the world. And in Asia, the smoking sort of growth is remarkable, right? And even in Europe. But we went smoke-free everywhere, not even in your car. Now, you ask, all right, so we made that. Did we decide we weren't going to hire smokers? No, we didn't say that. We said, we will give you every tool that you need, be it smoking cessation patches, be it coaching, be it, whatever it might be, we'll pay for it to help you smoke. We had thousands and thousands of people. GE has 300,000 plus employees. Thousands of people actually quit. Now, in addition to that, as it relates to other types of sort of carrot stick, and therefore this kind of what do you absolutely mandate on site or not on site, we know sodas cause that sort of situation, and everything in moderation, right? So what we've done is essentially change what's in the vending machine. And it goes to your points, everybody's points, as to environment. What do you have? What don't you have? And make that pretty persistent throughout. And then educate folks through webinars and everything else what, in fact, their choices might be. So I think people, it's back to your point that says this is a choice that people make that they believe they can over the long term. And
But are you helping them make that choice by saying you just can't buy a soda larger than 16 ounces?
we don't
or
allow
whatever?
it on site.
But
They
do
can go
people
do it
ask?
elsewhere.
Do people ever ask for that? So I think a lot of people just consume what's handed to them. We're kind of taught to clean our plates.
That's right.
And I don't think consumers went in and said, I really want to have the 16-ounce soda. I think that these sodas have gotten bigger and bigger and bigger. They were 6 ounces when I was
Super
a kid,
sized.
you know, and that people just generally will polish off whatever's placed in front
Well,
of
it's
them.
sold to you as being cost effective. An extra quarter gets you an extra 10 ounces.
It's super big, and I'll tell you, as a mother, I don't even mind mayonnaise because they help mothers.
Yeah.
So I kind of like knowing, how many calories are in things that I'm giving my kid, and being able to make choices on that basis. And I think more and more the people I know are starting to learn about that. Well, it requires education, and but I think that I don't see a problem with that.
So, we were publicly supportive of the mayor when he came out with this, partially because, look, the underlying reason for it is exactly to the point. There's been a lot of research done that shows that if you give somebody a full serving of soda served in a bathtub, they will in fact drink more of it than if you give it to them in a thimble. So that's an empirical observation.
There's an
That was paid for research.
It's paid for research. So the theory is that I think it's a very good point that there's effectively been an arms race where the consumer says I want value and the food industry responds and says I'm going to give you value, and you can't get a 16-ounce cup in a movie theater anymore. So like why I'm always amazed at why anybody would drink a 64-ounce Coke or Pepsi is just beyond my comprehension. But yet, curiously, it does still happen. Now, do I think that this legislation was going to change everything? No, I didn't. However, I do believe that creating kind of consciousness and awareness of the fact that our portion sizes have gone completely nuts is incredibly valuable. And so that was reason reason 2 for being supportive. Reason 3 is, God bless him. A lot of people are flapping their gums about obesity and what to do about it. And he is willing, as he has done throughout the entirety of his tenure as mayor of New York, to step up and do unpopular stuff that's going to cause people to throw rocks and garbage at him. And he did it once again. And on that reason alone, I give him a lot of credit for it.
Yeah, that turned into quite the debate. So we have 5 minutes left, and I don't know if there are questions that we have in the audience. Yes.
Words carrot and stick have been used. If we switch to the word incentives, what are the most effective positive incentives? And are there some negative incentives that people believe in but really don't work, so maybe we shouldn't use them? This is about changing behavior of individuals.
Well, I don't know if there are any behavior economists here, but there's a lot of rules that you're not allowed to incent, a lot of government rules. You cannot incent, they're called kickbacks. So there's stark violations, and there's just a lot of things you're not allowed to do. I mean, you can imagine how if you paid someone to show up to their follow-up appointments, if you paid someone to take their medication, there's, I don't know if there's anybody in the pharmaceutical industry here, but when people are prescribed medications, they may take it for a day or two, and then they don't follow through. If there were incentives to do that, but you're just not allowed to.
I would say that for me, I'd parcel into extrinsic and intrinsic. Extrinsic is financial, and we have found that there's a certain amount that needs to be applied on premium discount, which has a motivation, and we've seen that in our own program. And it starts off as a financial reward and ends up being a risk loss aversion application as it moves forward. On the intrinsic, I would say that it is the desire that we have to conform to the norm, whether you call it social proofing, peer pressure, what do you want to call it. We have an intrinsic desire to conform. So if your norm, the culture, is one around health, you'll intrinsically motivate individuals and incentivize them. So those two, I would say, would be the two most prominent for our organization.
Should I just speak
Sure,
louder?
yeah.
Yeah. So, first I want to observe there's a tremendous concentration of both wisdom and common sense. There is a tremendous concentration of wisdom, common sense, and even wit on this panel. And if a CEO wanted to get access to the commonality, because there's a good deal of consensus, but nevertheless a variety of solutions that have been mentioned, is there a place to go if a CEO wants to find out how he or she can apply this wisdom to his or her corporation? Is there a repository that brings us, or an aggregation that brings us together?
What we were talking about before.
Actually, there is. The National Business Group on Health, I think, does a pretty good job in terms of doing this. And most, I know GE's a member. I'm pretty sure Safeway's a member. So I mean, it's sort of most of the companies that are doing best practice, benefit design, employee engagement, those types of things, they participate through the MBGH based out of DC. And they have a huge repository of data and insight waiting to be tapped. But I think you raise a different question, which I think is equally interesting, which is, I think it's just incredibly valuable, and you see this with Safeway, is it's very different when the CEO is getting directly engaged on the health of his employee population, and without any disrespect at all to the HR folks, is that it's hard for those guys to lead the charge by themselves. And I think the more you see CEOs stepping up and providing leadership and getting personally engaged and involved and saying, you know what, this is a priority for us, good things will happen from that. And there's probably more that can be done to make this more kind of digestible and user-friendly for that audience.
Yeah, to be clear,
well.
I mean, I'm not talking about a repository, I'm talking about an easily accessible, easily digestible version that aggregates the insights that you and your various organizations have brought together. I think that'd be incredibly useful.
And less an HR issue, as we
Right.
discussed earlier.
Yeah.
Okay, over here.
I want to second what David Kirchhoff just said about CEOs and say you could say the same thing for mayors and other government officials. Dick Merkin said the problem is you can't incentivize things. And what we have now is you have the market for health care, you have the market for bad health, which is the non-diet sodas and everything else, and a teeny tiny emerging market for good health, which is things like fuel bans and the like. What we really need is for the government to get in there and do the same thing with elevators. Not, it's called paternal libertarianism or libertarian paternalism. You know, you still can buy you can buy 2 sodas if you want. You can take the elevator if you want. But the choices that our government inherently lets us make or forces on us are a huge part of the problem. And until you guys up there start focusing on them, it's not going to go away, starting with school lunches and so forth.
Bianna, can I just say
Yeah,
one thing?
yeah, cool. And then we've got I see the session over sign.
We're being told the session's over. So there is one activity which I am really, really excited about, coming back to your first question, and this is the education of America. And so the Institute of Medicine is teaming up with the producers, the ex-producers of Sesame Street and the ex-chairman of the Ad Council. And one of the things, when you think about deaths from accidents, our seatbelt situation, for example, and how much was put into place as it relates to awareness. When you think about drugs, just say no, and that this is your drugs. This is your brain on drugs,
the cigarette
right?
campaigns
The cigarette campaign, no smoking.
Yeah.
Fantastic education, right? But yet we haven't done that with health. The awareness of how we engage in health, or even know that there are choices in health, hasn't been done. So the CDC has also been involved with a number of programs with Healthy 2020, I believe the program is. There is this big push as it relates to getting much more awareness at the consumer level, using all the different types of media that now exist, which is huge. And I think any one of us can get engaged in that, and the more we do, the better off I think everybody
Again, no
is.
surprise in this day and age, this too has become a political issue. So, okay, we'll leave it there. Thank you so much. Thank you for a great panel.
Thank you.
Great to have you. Thank you.